The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Good morning, George. It's Tuesday morning. We have a phenomenal guest today on the podcast from your neighborhood.
Yes, today we have Dr. Kathy Caronia. I've known Kathy Caronia since 1996, 7, something like that, where we started out on Long Island together. And she has a fascinating topic, which is basically the history of the pediatric community of Long Island, hospitals working collaboratively within the community with their pediatricians for the greater good of all, especially the children. Dr. Caronia has a resume that's 18 pages long, so I can't recite it. So I'm just going to put the latest one: Senior Vice President of Academic Affairs, Chief Medical Officer, Chief Academic Officer of the Catholic Health Services, plus 18 other pages. Most important, she's the chairman of the pediatric department, and she's developed a lot of programs, too many to list.
And she's a peds intensivist.
Peds intensivist.
That's right.
Yeah, you know who I love the most, right?
Oh,
Pediatric ID, pediatric intensivist, all pediatricians.
Yeah. All right. So we'll start off with, like we always do, Kathy. Why did you become a pediatrician?
Oh, I didn't go into medical school saying I wanted to be a pediatrician. I had no idea what I wanted to do when I started. But certainly when I got to my pediatric rotation, and in all honesty, I loved all my rotations. But when I got to my pediatric rotation, I really felt that's where I belonged. And the children are absolutely phenomenal. They are forgiving. One day you go in to draw blood and they're upset and screaming and they hate you. And the next day you come in the morning and they're all smiles and they're giving you dolls to play with. Really, that's where I found my home. And again, went through my pediatric residency and then decided that critical care medicine was what I wanted to focus on. So I then did the fellowship in pediatric critical care. And
the rest is history. How did you end up becoming a pioneer pediatrician of Long Island? You must have worn 50 hats.
And that was not planned either. As a good friend of mine once said, I don't know how to say no. So
yeah, that's true.
Really coming on, I think, just working with incredible people, coming and being recruited here to Good Sam, as you said, in 1997, really to start the Peds ICU, our administration through Good Samaritan at the time, and then as Catholic Health really developed as a health system, really with the support of our administrative leadership, who really had the desire, the dedication to ensuring that the patients within our communities had the resources and didn't have to leave to go an hour east or an hour west, really pulling them out of our communities. And then really the rest is history in the sense that we were able to recruit incredible physicians. We had the amazing support of our community pediatricians that really, if you will, bought into that vision, who wanted that vision for the expansion of pediatrics. And we have been very fortunate to be able to continue to grow and to develop not only a PICU, but a general pediatric floor with hospitalists to support the pediatricians, with a newborn nursery, NICU, a level 3 NICU, a standalone pediatric emergency department, a pediatric residency, and a whole subspecialty center of specialists to support the inpatient wards, as well as our community and the pediatricians who practice within it.
Yeah, the interesting part about this, Dr. Bravo, is that, yes, they have hospitalists and all that, but they still allow the physicians, if they choose, to go and round at the hospital on their newborns and on their patients. And we work collaboratively with the residents, with the hospitalists, with the ICU intensivist. So I think this will lead into building trust and relationships with the medical community. How do you think, Kathy, a hospital system can establish and nurture a trusting relationship with the community pediatricians to ensure the successful partnership for everybody? I guess we can talk about the specialty care center, how it was born. I think that's where it started.
I think so. And I think when you say the hospital allows the pediatrician, I take it back and say it's the pediatricians who allow us to partner with and to care for.
Okay.
Our hospitalist service is there really to support the pediatricians and honestly for the education of the pediatric residents or any of our residents who rotate through there. But the patients are part of our community, but it's the pediatricians who have the patients, and they trust in us to care for, whether it's inpatient or whether it's outpatient, whether it's on the pediatric floor, and we cover vacations for pediatricians who perhaps need a weekend away or a week away, or God forbid they're sick and they ask us to cover for a short period of time, or all of their patients inpatient, or just for tonight. And we really do. We see it as a service to support the pediatricians, not to take over or to have a complete control of our patients and our pediatric practices within our community. I think the Pediatric Subspecialty Center has grown really out of the needs of our community. We have pediatric infectious disease, Dr. Bravo, you'd be happy to hear. We have pediatric cardiology, pulmonology, gastroenterology, neurology, nephrology, endocrinology, and they're all pediatric specialists, board certified, who really have set up their whole professional careers here at Good Sam, servicing our community and our pediatric practices. That developed slowly from 1997 as has just continued to grow, adding more and more specialists, bringing in state-of-the-art therapy, if you will, treatment. We just added a pediatric neurosurgeon, more pediatric endocrinologists, a geneticist with genetic counseling. So we really are building an entire children's program, and have built an entire children's program for the care of the community. And I think that comes out of that collaboration between the pediatricians and what their needs are and what their patients' needs are, right? And with that good dialogue, that good communication, we're able to work together to support the patient.
That sounds a lot like collaborative pediatric care.
So I'm going to interrupt for a
talking about.
second. Dr. Caronia, you remind me of one of my early mentors at Michigan State University, Dr. Charles Chavino. He was an intensivist like you, and he was a maverick like you. And he had one lesson to teach every medical student and resident that rotated through, this is back in 1989, through, they used to call it the Pediatric Referral Service, or the PICU. And his lesson was, the pediatrician owns the patients because they're there every day for them. And we are honored and entrusted by our colleagues to care for their kids. And you don't dare send a kid home without picking up the phone and calling the pediatrician, no matter how small of a town he lives in, and that you will never see him, and say, I got your patient here. He left the PICU on such date. He's been in the inpatient ward for 3 days. He's ready to go home. He's on these meds. He needs to see your office this date. Is there anything else I can do for you? I'd say, right. But they have a busy day. They're like, they care about their patients. They need that information so that when the patient shows up, they can continue the care. And then we would write a letter. I would dictate it. He would read it. He would edit it. And then he would sign it and put a note, because he knew everybody. He would say, George, haven't seen you in a while. Let's catch up. And that is what you have built. You're a maverick in pediatrics, but in Long Island, not in Kalamazoo, Michigan.
Yeah, she is, certainly.
Thank you.
And back to collaborative pediatric care. What is your vision for a hospital and the community pediatrician to work together for the betterment of the children? It's communications, right, between the specialist and the physicians in the community, right?
It really is. And medicine has changed. There's no doubt about it. From the time we first started here, close to 30 years ago, I can't believe it, 25 years, medicine has absolutely changed. And I know when I first came in and going through is, we are not here to compete with the general pediatrician. We are here to support them and their patients with subspecialty care. And I think we've really done that, shown that. And again, it's that open communication of what are the needs, from what do you want to hear about in grand rounds to what sort of services are your patients asking for, or that you are having a hard time gaining access to for your patients. And it's truly that communication. Now, medicine has changed, and as we know, there are practices. There's the independent practitioner, who I have to say I am completely in awe of, having never done a private practice in any way, shape, or form, or been involved with, and always having the backing of a hospital or healthcare system, with the ability for independent practices to grow and to flourish the way they have, especially in today's financial climate. There are pediatricians who are looking for acquisition that they just can no longer oversee. They want to do medicine. And I think that health systems in general have to appreciate both and all, right? Whatever those practices are, whoever those practitioners are, and their needs, it's truly collaboration, it's truly communication, and being able to support each and every one of them to our best ability. And I think that's just with really building relationships, which we've been able to do.
Where did that passion for serving? I always thought, I did a lot of PCR, peds urgent care, that I was an extension of the daytime pediatrician, that nobody can work 24 hours a day. Where did that passion come to you? Because you see yourself as an extension of the medical home in the neighborhood.
Yes. I think, honestly, when I made that transition to Good Sam, I think I came out of the Children's Hospital. That's what I knew. I did my residency, my fellowship. I stayed on as an attending. And at that point, I didn't recognize truly the role that the general pediatrician played until I got to Good Sam. And I really was able to make the relationships. By the time, again, in the Children's Hospital, by the time patients came to me in the peds ICU, the pediatrician, I don't want to say it was long gone, but was no longer involved in the care of the patient. And I think when I came here to Good Sam, it was a very different relationship that I was able to develop with the pediatricians, and that it was their patient. And I was here to service them and their patient, but return that patient back to them. And as you say, really an extension of that patient-centered medical home. And when we recruit and when we work towards the recruitment of, even in our succession planning for the future, really that's the type of people, the type of specialists that we're looking for. We're not looking to emulate the large health systems, perhaps without relationships, who are not able, because they've got 20 doctors in a division, and not able to form those relationships. We're really looking for those to understand the importance of relationship building, communication, and collaboration with the pediatrician. When we talk about patient-centered medical home, or the patient in the center, it needs everyone to be on the same page to make sure, including the patient, to make sure that the buy-in is there, that everybody understands the role of each other, right? And that we're all on the same page in the care. Otherwise, one broken spoke, the wheel is out of alignment. And we really need to make sure that we're able to, as partners, really develop that plan and care.
That's beautifully said.
Yeah.
I have another question. How have you been able to survive so long within a huge organization, a medical organization? What is the key to that survival and being allowed, I don't know in a better word, to build these relationships with the community?
I don't know how to say no, but I also don't take no.
We know that. We know that.
So I think the big piece is, and as we know, in large organizations, healthcare systems, and we all understand it, pediatrics has to be a mission. It has to be mission driven. As far as bringing in large amounts of money, your cardiothoracic surgeons, your orthopedics, your neurosurgery, they're the big finance drivers for health systems versus pediatrics. And I think it really is just the strive to be the best, and then surrounding yourself with physicians, staff, really who have those same beliefs, those same goals, regardless of the hurdles. Have there been barriers? Of course there have been. Have we grown as quickly as I'd like? Of course not. But we keep moving forward and identifying different ways and with partnerships, whether it's with our schools, whether it's with our pediatricians, whether it's with our communities, really to support the practice of pediatrics. And I think that's really what we've been able to do. But the passion comes from inside, and I think the ability to see growth, to see that we're making a change, enjoying the relationships that we have, and then finding the people to surround yourself that have that same desire, that same dedication, not those that are coming in and out as a fly-by-night once a week, and really being committed.
So I think everything goes around to relationships and communication.
Yes. Yeah.
With the specialists that we have in the hospital, I know them all.
Yeah.
And why do I know them all? Because I go to the hospital, I meet them in the hallways, I meet them at ground rounds, I have their cell phone and I text them all the time. The other places, I don't know who they are. They don't even know who I am, let alone I'm just a low pediatrician. Nobody pays attention.
You said something, so you're a phenomenal leader, just the way you speak, the way you build a team, the way you share credit, all the things that I value in a leader. But you said something very important in that, for lack of a better word, you work for a charity hospital. The Good Sam is committed to the community, not to the profits. They will back the mission of taking care of the poor, the underserved, the ones that don't make the most money, because they are part of every community. And they need it more than the person that can pay for the VIP service. That must be a big wind at your sails when you're trying to build these programs.
It is. And I think that only because of the vision and the support that we've been able to get here at Good Sam, as well as through Catholic Health, especially our CEO and president, Dr. Patrick O'Shaughnessy, is very incredibly committed to pediatrics and really sees us as a hidden jewel, as a children's hospital, having everything within pediatrics and putting that all together. And I think it is the mission. It's the same care for every child walking through the doors of any one of our institutions, and not looking at what is the payment of, but taking care of the patient. And not only the patient, but the family. And going through this, I think one of our bigger pieces that just shows that full dedication and commitment also is our Child Life program here. Child life is not often seen in community hospitals, and yet we've had it for over 20 years. They don't make money. Child life, it does not get paid for the services, and yet it is so extremely important, not only for our children, but their families. And they go into our ICUs, our adult ICUs, to help the children, even in those areas with perhaps family members who are sick or dying. Our palliative care, our hospice service, again, for the children of these families to help them. And again, that's all a non-reimbursable, if you will, service. And yet we have been committed to putting that into place really for about 20 years. When we initially brought that up, I actually was able to develop Child Life here through a grant. So we were able to get our first Child Life specialist. And again, that's I never take no, I'll find a way. And then they saw how wonderful it was, and we've expanded that program, and certainly it has grown dramatically. So it really has worked. And I think it's really the mission, as you say, of Catholic Health, to support everyone from birth, pregnancy and birth. I say that becomes where pediatrics is, it becomes part of that family's life. And we continue to care for children even into college, just like
That's
the pediatricians.
important.
Absolutely.
And George has nothing but praise about you, which is unusual. George doesn't praise very many people.
Thank you, George.
Thank you.
Tremendous admiration for you and the job that Good Sam does. And looking from the outside, it seems to me that you have the magic sauce.
Yep.
You're mission driven. You treat everybody the same. You respect others, but also very importantly, Good Sam's run with a dyad, a strong physician leader with a strong administrator that can implement the vision of the leader. And that, I think, is crucial. We see it over and over again in the success of medical organizations. How does that play a factor in your ability to continue doing what you're doing, that dyad at Good Sam?
Again, I think it just makes everything fit and be put into place. I think what I always say, I don't have the greatest ideas. I see myself as the facilitator. When we work with our pediatricians or at certain divisions, our GI division or pulmonary, they are the experts. They are the experts in general pediatrics or in pulmonology or gastroenterology. What do we need? What do we need to grow, to develop, to support the patients? Are there new ways of doing medicine that we need to incorporate into our practices? I see myself not in identifying those because I'm not that smart, but the ability to facilitate, to support and say, what do you need? What is it that you need to get the job done? That's where I see myself as the person to do that work. We saw that during COVID with COVID vaccines and putting that together. And again, it was to help not only to provide those at our center, but also to help the general pediatricians to be able to provide it to their patients, whether it was at our center or within their offices, and to work with them and really to help to develop new programs throughout. But I think you need all of the pieces. You need that support from your administrative leaders to believe in the vision and the passion. And what I found is because of our passion, we have taught our leaders the importance of
I believe that. But you know what? I've been around long enough to see lots of hospitals fall apart, go out of business. And the one recurrent theme that I've seen was every hospital that closed its pediatric emergency room, closed its pediatric ward and maternity, ultimately died, because pediatrics is the seed. The child is born. They go to maternity. They get seen. The child gets sick. They go to the emergency room. They get admitted to the hospital. The parents get older. They go to the emergency room, the same one. Then the grandparents get sick, and they end up with the surgeries and the hip replacements. It's just a cycle of life. And PEDS is the seed. PEDS and OBGYN. Every hospital that closed them down, finished.
And
that's not our experience here, but
really?
Yeah.
No.
Oh, really?
I'm talking about the smaller hospitals.
No, the smaller hospitals can make a lot of money if they stop delivering babies and having PEDS and wards. And if you look back at history, the pediatric emergency room didn't really come into existence until probably 1990 or so. Before that, only the big CHOPS and Cincinnati Children's had dedicated pediatric emergency rooms. The community hospitals didn't have any care for the kids in the ER. It was an adult trained physician. And often before 85, 88, there wasn't even a emergency medicine residency. You just were an internist and you weren't happy with the office and you went to work in the ER and you saw everybody, or you were a general surgeon and you saw everybody and you learn as you go, as you went. The margins are not there in pediatrics, and the smaller the hospital is and the less mission driven they are and the less they have the dyad of a strong physician leader with a great administrator, the more likely they will stop the lines of services that have no margins and move into the orthopedic surgery, which is easy, high volume, high margins, and make that little community hospital very profitable.
That's why it has to be the mission, really the mission of caring for the entire family, right? Being really supportive of, as George is saying, from OB through hospice, palliative care, geriatrics, the whole gamut within a health system.
Yeah. So now technology. Technology is important in medicine today. Before it used to be relationships and collaboration. I guess now you have to add technology. How do we work with the technology? Lots of places, they want to have the same system across the board. Over at Good Sam, we have pretty good technology. The Epic, the Haiku, that you can access everything on your phone. Worst case scenario, you can get a simple fax. But I see patients, they come post-hospital visits, post-emergency room, the specialty. We always have the records scanned into our system.
We do. And I think that is one thing Catholic Health really did put a lot of financial dollars into ensuring that we got the best of the best, right? Of our ability to communicate between each other as well as with our specialists to make sure that the access was immediate. And we really do. We monitor that all letters and items are going out to our pediatricians,
Right.
That there is that communication and that everything certainly is up to date. And again, that's, as I said earlier, that my job is to facilitate a GI needing capsular endoscopy equipment to provide for certain patient access. That's my job to find and identify how we're going to get that in place for them. And again, with the supportive administration, we've been successful in securing what those needs are.
But with technology comes challenges.
Yes.
Hackers, HIPAA, it's pretty scary stuff.
Yeah. And as most health organizations and health systems, there's the monitoring, the ensuring, and it's a full system-wide department to monitor and to ensure that there are no breaches. But yes.
I had a patient his major is cybersecurity of the health systems.
Oh, wow.
And I had asked him, I said, why in the world would anybody want to hack my medical record? Who cares? Uh-huh. He says, no, doc, they just do that to hold the computer system hostage so people can't work and can't access records to treat patients in the hope that the system will pay. That's like terrorism.
Exactly.
It is terrorism.
Yeah.
Because they can't do anything with the records. Who cares about Dr. Bravo's problems, really? Right. Medical problems. Psychiatric problems or whatever.
Well, we don't want the whole world to know about my psychiatric problems, please.
No, but then that goes back to HIPAA because of the HIPAA laws. They're so severe. If they breach, somebody has to do something. So I wonder if we want to do good with HIPAA and we just made it worse. I don't know.
HIPAA is very old, right?
Yeah.
In terms of technology, like we talked about the other day, we had the industrial revolution of medicine that started between 1950 and 2010. And that was vaccines, antibiotics, some monoclonals, Da Vinci surgery, endoscopies, MRI, CT scans, minimally invasive surgery, bedside ultrasound, all sort of phenomenal, but not rapid changes. And now we're shifting. If you look at what happened with the COVID vaccine, they could get that produced in 10 months, right? That technology is coming. It's coming rapidly. And HIPAA was designed for when we were still doing the assembly line. And now we're at a whole other level. When HIPAA was designed, texting was not a thing. WhatsApp did not exist. The iPhone was not around. People don't like patient portals. People want to text or send you a message through WhatsApp. And the younger the person is, the less obsessive they are. So I get a text, and if I don't respond with it within 5 minutes, it's like I'm being paged and I'm ignoring it because I am old. But you send a text to a 16-year-old, he looks at it, he says, I don't have to answer that now. Maybe tomorrow you get a little thumbs up. And they're not bothered by it. But we have rapidly changed, and HIPAA has not been updated for the way the world is in 2023. And it really needs either to be completely thrown out and rebuilt or to significantly be improved because people don't like the way we're communicating with them.
Right.
Yeah. And in regards to patient portals, I had a discussion with some physicians about with the MyChart and the patient portals and stuff.
Yeah.
With their new regulations, the entire medical record is up there for them to read everything.
As soon as you sign it. Absolutely. Yep.
I don't know if that's a good thing or it's a bad thing because I know like with laboratory testing and peds, we have lab tests. There's some abnormalities, but nothing crazy. And patients, they don't know because they didn't go to med school. They question every little red blip. And what is this? And what is this? And what is this? That has to be a big time suck on the internal medicine population of physicians. Yeah. It drains us, but it's still, should we give so much access?
No, absolutely not. I'll tell you my perspective from my parent, my dad. He's 85 years old. He's in overall good health, but he has problems. He's 85 years old.
Yeah.
So he has aortic stenosis. He complains. I'm like, Dad, you never had a heart attack. You never spent the night at the hospital. You had one surgery because you had a subdural hematoma when you were 83. Wow. You really have lived a blessed life. You walk, you drive, you watch the news, and you ask me about ChatGPT. But he obsesses over the notes of his cardiologist on Epic and downloads it, reads it, sends it to me, highlights it. And I'm like, Dad, I don't know what the difference between 0.9 centimeters aortic valve and 0.95 is. I don't do that for a living. But your cardiologist said, we don't need to worry about it right now. So put that in the trash and go outside for a walk. I got to stay informed. Informed about what? Have you ever performed a TAVR procedure? No. Then what are you going to get yourself informed about, Dad? This is not for you to worry. You're paying people who put years and years and years in educating themselves to understand the nuances of your disease at this point. His cardiologist is phenomenal. He's Romanian. And he says, I don't know what to advise your dad. There are not many 85-year-olds in this good of health. We don't have data on what to do with 85-year-old healthy people. And so we can't really do evidence-based medicine with your dad. And understand that at some point, life ends no matter what we do. But for my dad, this just causes anxiety. And the anxiety spills over because I have to deal for it. I wish they would just shut this portal down and not let him see that its creatinine is 0.10 above normal. Who cares? You got a good quality of life and you're not in dialysis. And that's what we're supposed to do as doctors. Translate all this mumble jumble to the family. You worry about this, you don't worry about that. You put a helmet on your kid, he's going to fall off the bike no matter what, but he's a kid, he's got to learn.
Yeah.
You put
who came up with this idea to give all the records to everybody?
Part of high tech.
High tech?
Yeah, that was during the Obama administration with the new EMRs.
Wow.
You're right. Doctors need to translate the information that we document in a chart for the patient, but you're documenting a chart. So now it's almost like you need to document in a chart for a patient to understand it.
Yes.
Which will be a very different way of potentially documenting, right? It's no longer just putting in that aortic stenosis and the values, but now writing what that means and translating it within a medical chart that doesn't quite make sense.
So we don't have the time to do it because we're not paid enough for the work we do. But the ideal EMR, in my mind, would be very much like how a lawyer works. If you ever met with a lawyer, they still have a yellow pad. And they take notes, and they got all the folders of all the pleadings they've done, and they take all their notes in the yellow pad. In court, in their office, they're never going to give you their yellow pad. That's their internal deliberations of the facts, the law, and what they've counseled you on. And then they dictate a letter. And that letter may be dictated to opposing counsel, to the court, but it's often to the client. Here is our conversation. This is what I need from you. And this is what I think are the perils of that you're in. And this is how I think we can solve your problem. Because I'm not a lawyer. I don't know the black letter of the law. And I don't have time to read it. That's why I'm paying a lawyer to tell me what I'm supposed to do. If the EMR worked properly, we will have a yellow pad where I make the notes of what's important to me as a physician. And then now with ChatGPT, natural language processing, it would translate it into, this is what you need to know as a patient. This is my letter to you, Mr. Son. So you know what we did and what we're going to do next.
But it also has to open up a lot of medical legal avenues for lawyers to look. They basically, they have everything there in real time, and maybe lawsuits that shouldn't happen just because of access. I don't know. We should always do the right thing, of course, but sometimes what we think and what we write may lead people to look in a different direction and could cause problems.
Yeah.
I don't know. What are your thoughts on ChatGPT, Dr. Caronia?
I don't know.
I don't know.
No.
She's focused on the relationships.
The relationships.
That's right. I don't know.
That's right. ChatGPT doesn't do relationships.
No,
no.
it's
They
Rise
just
of the
do-
Machines.
They
right,
just do
they're
word
machines.
vomit.
Yeah, it's Rise of the Machines.
That's right.
Yeah, so I guess with all these relationships and all these things, collaborations and networks and people, we got to measure this. How do we measure this? How do we go to a suit at a system and say we can't say we're doing a good job because I know we're doing a good job. What do you do?
I think it really does. It comes down to, fortunately, sometimes it comes down to just volumes of, right? If we're doing a good job in endocrinology and we see sudden growth and development of and workforce, that's what administration may be looking for.
Yeah, they look at numbers. So back to the
But
dollar
what we
sign.
look for, and that becomes part of our performance improvement, our quality assurance going through. Yeah, and so those are those pieces, but there's that quality portion of it. And we on our performance improvement for pediatrics for each site not only have specialists, but we also have our community pediatricians who participate. And actually, our quality improvement, our performance improvement committee here at Good Sam is led by one of our community pediatricians and has been since the inception, I would assume, of pediatrics here at Good Sam. And that's really, again, there's no barrier, there's no secrets, right? It's truly looking at, and what we look at not only are how patients are cared for and have there been any concerns about care, whether it's at a subspecialty level, whether it's at a nursing level, whether it's at a community pediatric level of seeing patients and caring for patients, as well as looking at all of our transfers out of the institutions and seeing, are we doing the best for our patients and what else do they need? And I think, again, it's just respecting one another and truly transparency, right? To say, look, our books are open, here they are. How do we come together with all of the skill, with all of the experience, with all of the knowledge from every aspect, from everyone? And they're closed door meetings, but they're not closed to our pediatricians, to our physicians, to our specialists, and anyone who wants to participate in these committees. We welcome them. Because again, everyone comes with different experiences, different needs. And it's, again, goes back to that communication to identify, are we doing a good job? We talk to our pediatricians, we talk to our specialists. How are our patients? What are your needs? What do you need to care for your patients? What are some of the struggles that the pediatricians have? Some barriers. I remember quite a number of years ago, George and I put together a meeting, if you will, with pediatricians and with our ped subspecialists. And we had a wonderful showing. And my first opening point was, I'm not here to buy your practices. I'm not here to acquire your practice. I'm not here to give you computers. I don't have that. What I'm here for is really to bring us around, with George's help, to a table where we can all act together for the good of the patient and identify what it is. We can't live in silos.
We basically, remember Dr. Espinoza?
Yes.
His vision of the medical neighborhood?
Yes.
It was born in that room. Yeah. And it wasn't until that day I knew of Dr. Espinoza, but I've never met him personally up until then. Now he's the vice president and he's involved, and he's a genius.
Yeah.
And so, Dr. Caronia, you have a great vision.
Yes.
Supervision.
I hope so. Well,
how do we sustain this and how do we expand this collaboration?
I think again, and you bring up that meeting, and there were pediatricians who were not part of Good Sam, that had no medical staff privileges at Good Sam. We basically put it out there and bring your friends. The more the merrier, if you will, like again, in one room to really communicate. I think it's really making sure that we are surrounding ourselves, working with people who are coming in to our communities, within our practices, whether they're hospital-based or they're independent, who have that same vision, who really can continue that work, understanding the mission, and really believe in what we're trying to do. Giving them the opportunity to come to the table, if you will, to make decisions, to bring thoughts and ideas. Again, I'm not a top-down leader. There are times I have to make decisions, obviously, and they may not be the most popular, but that's just part of being part of leadership. But anyone can bring a thought, a concept, a goal, a new program, a project to the table. And really, I think that's what that's about. But you need people who want to do that, who are dedicated to the community, to pediatrics, to the system, to our pediatricians, really for the betterment of what we're doing here, not just for a job, to come to work and go home.
This is a hard conversation or question to ask, but how do you balance the margins with that mission and vision? Because at some point, we all have a finite resources, whether it's time, money. How do you navigate that? Because that's a very difficult thing to do when you're so passionate.
I think it's, again, coming through being open with your physicians, whether it's on a productivity model, but coming together and not just saying, okay, we've signed your contract, you're on a productivity model, and in a year we'll come and take a look at it. It's really meeting, working with them. In order to build, in order to grow, we do have to have margins. There has to be money that does support what we are trying to do and for the growth and development. But I think it's really partnering even with my doctors and subspecialty. It's not that they work for me. I like to say I work with them and sometimes for them, to make sure that they're successful, because their success is my success, is Catholic health success. And I think that is really true for all of us. And the ability to say, you're not just joining, whether it's as medical staff or as an acquired practice or as an employed physician out there all by yourself. You're given the ability to grow, to develop your professional careers as you'd like to see. But we have a primary obligation to help you to do that. And that honestly has been successful. And maybe it's getting the right people. I've been extremely blessed to be surrounded by incredible professionals who really love what they do and do it very well.
Those physicians,
in a good world,
those specialists that you have, they've been there for quite some time. And they seem to be passing on the culture of Dr. Caronia to their new doctors. And I think that's what's important, because the generation of today, it's like they flip and they change jobs every other year. I've seen resumes of physicians that had in 10 years, 12 jobs. How can that be? I don't understand. They don't build any relationships with anybody.
Well, we did an interview. Was it the cardiologist is phenomenal that operated on the girl from the war zone?
Oh, Dr. Lovechuck.
What a phenomenal
he's part of CHS also.
What? And
yes, he is. He's in my
and he talked about
great.
how you guys have a joint project that funds emergency surgery for heart patients across the world. What a beautiful story. What a beautiful story. George undersold you.
Undersold?
Yes. Wow. She's a phenomenal leader.
She is.
And she has everything I look forward in a leader, right? She shows up. She has hope. She's intentional with her words and her actions. She's humble and willing to listen to others. She's not the smartest person in the room.
Yeah.
And she is mission driven with a single focus to serve the community. And so I asked this of Dr. Offit and he turned me down, but will you run for U.S. president?
U.S. president.
I don't know if I'm ready for that.
That was better than Dr. Office that he said absolutely not.
Absolutely not. Yeah.
So maybe I can just work on
I have too much work here.
Yeah. So we're getting
Remember,
to the
I
top.
think-
We're getting to the top of the hour now. I know Dr. Caronia is very busy, and I just want to end this with the following statement that my father told me: if one does good quality medicine, then the money will follow. But if you follow the money, nobody will ever do good quality medicine. You'll never be a good doctor. And that's from my father was a general contractor businessman. What did he know? But he's right. What are your thoughts on that?
Absolutely. Yep.
Makes a lot of sense. Sounds like Dr. Caronia's vision.
Me.
It sounds like your vision.
It's true. It's true. And we build it, they will come, and we'll be able to build more. That's really what it's about.
I've seen places that build it and nobody comes, and they're missing something. They're missing the secret Dr. Caronia sauce.
Leadership.
I don't know about that.
Leadership
is incredibly important.
Yeah.
Leadership's incredibly important.
Yeah.
All right. Thank you very much.
Thank you.
Thank you. And thank you for inviting me. This has been great. And what I cannot say enough about what you guys really have put together and what you're doing. It's absolutely wonderful. And just keep it up. They're so informative, your podcasts. They're fun. They're great. I learn something every time, and I appreciate that. I get the reminders and those, and just keep doing what you're doing. It's amazing.
We have to elevate great physicians like you at all times.
Yeah. Thank you, Dr. Caronia.
But you, George, are absolutely. Oh, you're welcome. An outside of the box thinker, and I've always said that, and that's what we need. We need that outside the box, not just follow the person in front of you. And
we know
really
that
what you guys are doing, and you're bringing this really to the forefront.
Yep.
So that's great. Thank you.
Thank you.
Thank you. Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.